High effectiveness and safety of anti-CD7 CAR T-cell therapy in treating relapsed or refractory T-cell ALL. The products was prepared from Hebei Senlang Biotechnology Company, and the clinical trial was conducted in Lu Daopei Hospital in China. I have nothing to declare. Effective treatment are still lacking for refractory relapse T-ALL. Once relapsed, the majority of patients only have a slim chance of long-term survival. Compared with the substantial efficacy of CAR T therapy that has achieved in B-ALL, CAR T for T-ALL is still being explored in early stage of clinical trials. We developed the anti-CD7 CAR T therapy with a novel platform. We conducted a phase 1 trial to investigate the safety and efficacy of CD7 CAR T therapy in T-ALL. This slide shows construct of anti-CD7 CARs. Basically, this is second generation of CAR T with a 4-1BB as a co-stimulated domain. In our preclinical study, we compared 3 methods for deriving anti-CD7 CAR T cells. One, we call the naturally selected anti-CD7 CAR cells, NS7 CAR, in which we transduce anti-CD7 CAR into bulk peripheral T lymphocytes and allow CAR T cells to merge in vitro after fratricide. 2. CD7 knockout CAR T cells, we call the KO7 CAR, derived by CRISPR-9 gene editing. 3. NEK7 CAR, in which anti-CD7 CAR cells were transduced from purified CD7 negative T cells. We also had an abstract presentation regarding detail about those structure. If anybody interested, you may look into that in this ASH meeting. In our preclinical study, we did a comparison of 3 manufacturing methods for generating anti-CD7 CAR T cells. NS7 CAR had a lower fold expansion than KO7 CAR and NEK7 CAR in vitro. NS7 CAR had a rapid and dramatic phenotypical transition from CD7 positive CAR to CD7 negative CAR T cells within a week. CAR molecule expression in NS CAR up to 92.4% was significantly higher than KO7 CAR or NEK7 CAR. Both NS7 CAR and KO7 CAR showed a comparable cytotoxicity and released high level of gamma interferon and TNF-alpha, but NEK7 CAR to a lesser extent. Both NS7 CAR and KO7 CAR had a robust protection against leukemia progression with a marked reduction of leukemia cell burden in our animal mouse model. So both NS CAR or KO7 CAR could be used for clinical trial. However, the benefit of NS CAR is that without needing for additional gene editing. For our phase 1 clinical trial, 14 refractory relapse T-ALL patients were enrolled with the median follow-up time of 210 days. Single dose of CAR T cell were infused to each patient with 3 dose levels as options. The median transduction efficiency was 93.8%. We have a 100% manufacture success rate. The median age was 17 years old. Median bone marrow blast before CAR T therapy was 11.5%, as high as up to 65%. 6 out of 14 patients also had a blast detected from the peripheral blood, such as 1%, 4%, 15%, 33%, even up to 62%. Median lines of prior therapy was 5. 3 patients were relapsed after prior allotransplantation before CAR T therapy. 5 patients had extramedullary disease involvement, including 3 had CNS leukemia, 2 had diffuse extramedullary disease, 3 had localized EMD. Patient also had a high-risk phenotype and genotype, including 3 patients had ETP ALL, 3 patients had a STIL-TAL fusion gene. Complete bone marrow evaluation was done on day 28. 13 out of 14 patients, up to 92.9% patients achieved MRD negative CR or CRi. Extramedullary disease status also evaluated. 4 out of 5 patients with extramedullary disease achieved MRD CR at a median time of 30 days. 1 NR patient shows no response both in bone marrow and in extramedullary disease, who had a STIL-TAL fusion gene and found to have lost CD7 on day 28. 11 out of 13 CR patients underwent consolidative allotransplantation. 10 patients still remain MRD negative at a median follow-up time of 213 days. 1 patient died on day 102 from transplant-related mortality after second allotransplantation. This patient had a prior allotransplantation before his CAR T therapy. 2 out of 13 patients without the consolidation allotransplantation. 1 still remained MRD negative on day 180. 1 who had a STIL-TAL fusion gene relapse on day 43 with CD7 lost and died on day 83. Regarding the safety, 13 out of 14 patients had CRS grade less or equal than 2. Only 1 patient had grade 3 CRS. Only 1 patient had grade 1 neurotoxicity. From the period of CAR T infusion to right before allotransplantation, no clear increase infection was seen, except 1 patient had CMV activation detected. 3 out of 11 patients with transplantation developed acute GVHD. 3 had chronic GVHD up to the last follow-up. CD7 CAR T cell expansion and persistence was measured by qPCR and flow cytometry study. You can see the median peak anti-CD7 CAR copy by qPCR was 2.38 times 10, and the median peak time by qPCR was 20 days from 10 to 42 days. Median persistent time by qPCR from the last measurement was 52.5 days, ranging from 20 to all the way to 120 days. In terms of flow cytometry study, the proliferation proportion was near 85%, and the median peak time by flow was day 15, ranging from day 7 to day 21 days. Conclusion: our phase 1 study of anti-CD7 CAR is safe and highly effective in patients with heavily pretreated refractory relapse T-ALL patients, including those with extramedullary involvement, prior allotransplantation, high-risk subtype. However, patients with STIL-TAL fusion gene tend to have a poor response and early relapse. Most patients are able to achieve MRD negative CR/CRi on day 28 and maintain progression-free. When relapse, loss of CD7 expression was observed. The majority of patients only experience mild to moderate CRS and no severe neurotoxicity. More patient and longer observation time are needed to further evaluate the efficacy and the safety of the anti-CD7 CAR. Thank you very much for your attention.
Thank you very much, Dr. Liu. Congratulations, really nice results. I will start with a online question that was texted to me by Dr. Rizwan Rami. Why did you or did you not see fratricide in the ex vivo manufacturing? If you did not, why do you think you did not?
Actually, as the NS7 CAR actually was CD7 negative by flow cytometry. So originally, we thought that the NS7 CAR was must be originated from a naturally occurring CD7 negative cell population. And or from the cell that became CD7 negative during the in vitro fratricidal selection. However, recently, we actually find out there is significant CD7 mRNA and the protein level actually was detectable by RT-PCR and Western blot in NS7 CAR, as well as in control T cell, but obviously not in NET7 CAR or KO7 CAR. So therefore, those CD7 molecule in NS7 CAR, so we thought it was antigenically masked, or actually, or intracellular sequestrated by the CAR. So this is what we think what's going on for the NS7 CAR.
Great, thank you. That makes sense. We have time for 2 questions. Is that Jacob? Okay.
Sorry, great talk, thank you. I was wondering if you had any information on the immune responses in the extramedullary disease lesions as opposed to the bone marrow of these patients, and whether you had any molecular or phenotypic data that the T cells were experiencing a different immune microenvironment.
Actually, we do not see that different. What our experience is that if you have a very bulky extramedullary disease, then the versus if patient have a multiple area but more diffuse extramedullary involvement, we see actually the anti-CD7 CAR works better for those more diffuse or multiple area instead of for bulky mediastinal disease. We're actually going to also present our work for those anti-CD7 CAR for treating T cell, acute T cell immunoblastic lymphoma patient. What we observe is if patient have a bulky mediastinal mass, for example, 2 of our patients we're going to report tomorrow, and if their mediastinal mass is like more than 7 centimeters or near 10 centimeters, those patients are not working very well. So still, you're going to have some penetration problem or microenvironment problem. But in terms for our acute, the CNS leukemia patient or other diffuse involvement patient, they still working very well.
Thank you. We'll take 1 quick question and a quick answer, please.
Okay. Hi, Glenn Raffel, Cambridge, Mass. Do you know if there's any persistence of the CAR T after the allo transplant?
Yes, that's a very good question. We actually observed low level of those CAR T by qPCR even after allo transplantation. For example, 12 out of those 14 patients, even after allo transplantation, we able to detect a low level somewhere around a median about 3.5 times 10 to the 1, but ranging can be as high as 6 times 10 to the 2. The copy levels. So that's what we observed.
All right. Thank you very much.